I'll be presenting some of the work we've conducted in Kenya, which examines the interaction of vulnerability, agency, and the research encounters among families of acutely ill children. This empirical work brings together two collaborations. One, the resilience, empowerment, and advocacy in women and children's health research REACH study, which comprises of experts from various disciplines in 4 countries. The overall aims for the REACH study are to understand the dilemmas which arise after studies involving vulnerable individuals have been approved. How can or ought research be used ethically as a tool to respond to complex and structural vulnerabilities encountered in research in under-resourced settings? And what this means or are the implications for ethics guidance on conceptual accounts of vulnerability in research. This research is embedded within the Childhood Acute Illness Nutrition Network, that's CHAIN, an observational cohort study which is being conducted in 9 sites across Africa and Asia. The overall aims are to understand the biomedical and social risk factors for childhood mortality during and after hospital admission. The study is recruiting a cohort of about 500 children per site who are below 25 months old and following them up to 6 months. And in-depth qualitative work is being conducted in only 4 of the 9 sites. For the purpose of this presentation, I will focus on data from 1 Kenyan site. Here I present some contextual background. So Kilifi is one of the Kenyan sites for the CHAIN study. It is predominantly rural with diverse but high levels of poverty and health needs. The majority of the population are from the Mijikenda community, and Kilifi hosts the headquarters of the multidisciplinary KEMRI Wellcome Trust Research Institute. And I would like to mention that we are located within the Kilifi County Hospital, where we have a long-standing relationship. Careful attention to ethical issues is always encouraged across all studies by the KEMRI Wellcome Trust Research Program. This is supported through, for instance, an extensive community engagement program, which is aimed at strengthening mutual understanding between the research institute and the local communities, as well as ensuring locally responsive and appropriate research studies are conducted. There is coordination across studies in processes and procedures, for instance, consenting and compensation to promote fairness and minimize inconvenience. And the Institute also offers support to health services and systems, and particularly to pediatric services, regardless of study participation, to ensure a basic level of care, encourage free choice in studies. The ethics-related support in Kilifi that is of relevance to CHAIN include, first, there's the broader ethical need for an observation study in a context with high morbidity and mortality, despite adherence to national guidance. And all aspects of the study are continuously reviewed, and referral and auxiliary care plans have been established. The study also encourages collaboration between clinical teams and social scientists with regular feedback sessions to ensure it remains ethically and scientifically sound. So basically, CHAIN was observing standard of care administered according to national guidelines with some additional collection of samples and questions, but not testing of an intervention. As mentioned in the previous slide, CHAIN observed standard procedures within the Kilifi County Hospital, and this slide illustrates what usually happens. Patients come to the hospital. They observe varying lengths of waiting period at the outpatient department, the OPD, and depending on the clinical elements, if they require admission, they are sent to the general pediatrics ward or the high dependency unit. CHAIN was embedded in and was observing normal care processes in the pediatrics ward, including the high dependency unit. And children were triaged on admission, and those needing immediate resuscitation were excluded or treated. The rest were either consented on admission before treatment or assented at that point. And I would like to mention that's where we have the red star in my slide. Consenting was deliberately done earlier on were clinically possible to ensure that learning from the study was maximized and to allow initial samples for research to happen at the same time as routine admission samples, so as to minimize discomfort for children. In specific to chain, acutely ill children across a spectrum of nutrition status were enrolled at admission and followed up during admission and at days 45, 90, and 180 after discharge. Several samples, including blood, stool, and anthropometric measurements, were collected throughout the admission and follow-up clinics. And I would like to mention that for chain, consent has to happen before any clinical care happens, and then the rest of admission procedures in research happen when admitted. So after discharge, parents are asked to bring the children back to hospital for the follow-up clinics. And the study visits are independent of nutritional or clinical care being received, but parents are advised to bring the children back to the pediatric ward or study clinic if sick. Additional to routine clinical care, bus fares were covered, and if children were found to be sick, they were referred for care as needed. Our embedded rich empirical ethics work conducted in-depth interviews with family members of 20 purposively selected children for over 18 months. The children had been selected on basis of quite diverse attributes, including their nutritional status, household and socioeconomic status, and geographical location. Clinically, they included those who had been diagnosed with severe wasting or kwashiorkor, moderate wasting, or no wasting. But we also had a few children who had chronic conditions like epilepsy or sickle cell. I will present some learning on each of these in turn, first drawing on lessons from the family members about their journeys through care seeking to understand influences on children's vulnerability to poor outcomes. Secondly, to understand how research featured in family members' narratives, including processes like consent. Then reflect on implications for doing research among vulnerable populations. We gathered rich, diverse data from families, which highlight some ethical issues arising and stemming from household vulnerability. In summary, and according to the caregivers, some children had been sick since birth, while others weren't, and a few were born preterm. We also learned that the education level of parents varied. Majority had experienced some social disruption events like relocation, birth of a sibling, loss of an income, or death within the households. This richness shows that even with this group of participants, there were some distinct but also subtle differences across the households. Our findings show that many caregivers were arriving at the county hospital after having undergone a complex and lengthy period of treatment seeking. We observed that children were often first monitored at home, sometimes for extended periods before being taken to healers, public hospitals, or small private clinics. Most participants reported treatment-seeking journeys for at least 3 months before admission, with particularly lengthy treatment-seeking journeys for children diagnosed with severe wasting or kwashiorkor, moderate wasting, or another chronic illness. Many had experienced significant challenges and demonstrated considerable efforts to reach and receive care, often visiting multiple healthcare providers and incurring financial costs, some of which are still to be paid to family, friends, and facilities. The parties discussed highlighted a complex interplay of vulnerability and agency, albeit constrained by family members' situations at individual, community, and health systems levels. For example, we note experiences of hunger, financial challenges, fears about their children's health, challenges accessing funds to support a treatment option, and some actions were based on perceived quality of care. However, some form of agency were observed and were not separate but seen to influence situations of the households in terms of seeking out and acting on advice which emerged from the concerns and fears about the children, getting loans to access care, negotiating to access care on credit, as well as negotiating delays in paying rent, which provided some form of relief but also added a burden of paying back. Here, we discuss how research featured in family members' narratives, including consent processes and overall perspectives of the research experience. We have noted that parents were arriving at the Kilifi County Hospital after lengthy and sometimes frustrating care-seeking journeys, and consent was seen to add to their emotional context. By the time caregivers and family members were arriving at the pediatrics ward, where consent processes were taking place, emotions were described as particularly intense. Family members discussed a range of emotions, including worries, anxiety, confusion, feelings of annoyance at the process were cited, including, as illustrated in the quote, being overwhelmed. I was approached by 4 doctors. Everyone came, asked me questions, wrote somewhere, and left. And then again, you're called by someone else. Initially, I was annoyed, but because we'd gone there for children assistance, I got used to it. Parents described making free and voluntary choices of joining the research study, but also hinted at some pressure to decide. Many reported that they chose to join because they wanted their children to get well or understand what was ailing their children. There are those who presented with heightened expectations, like getting their hospital bills paid, and a few who were unfamiliar with the hospital thought it was just a normal procedure. However, several reported feelings of under pressure to decide either way. This quote further illustrates the pressure related to vulnerability context. I was tired. There's no hospital I'd not been to. I had visited many hospitals. One tells you this, the other tells you that. So I wanted to know what the problem was. They told me when they carry out a blood culture, they will know where the problem is. So I accepted. We noted broader concerns across the research encounter in relation to the blood samples that were collected, wondering whether it was dangerous, painful, or what would be done to the samples. Some reported in the wards being warned by others about research participation, questioning what the reimbursements were for, and wondering if we were paying for the samples. There was anxiety around end of study, especially for those parents whose children had been diagnosed with severe wasting or kwashiorkor. Generally, parents reported positive research experience, with many appreciating the thorough investigations, better staff attitudes, and regular follow-up clinics. But few described research elements as learning for the benefit of children in future. And what we were eventually left wondering about was whether all this suggests some form of therapeutic misconception. This shows that research experiences interplays with individual vulnerability and agency. And we can see consent as adding to their worries, the fears and follow-up clinics, for example, adding to new responsibilities or burdens. But parents are also seen asking about payments, clarification for some study details, including voting with their feet when not happy by leaving or failing to turn up for some clinical visits. Bringing some of this together, what we see is the research experience, level of anxiety, interest, and ability to question, and types of concerns influenced by the type of study and procedures involved, and the consent information, as highlighted in the orange box, but also very importantly, by when those research processes are happening, and the broader situations in terms of treatment seeking and influences on that, and that is the layers of vulnerabilities and some abilities influencing the overall treatment-seeking pathways at individual, child, family, community, and health systems level. However carefully designed a study is, research teams will have to plan in place to respond to vulnerabilities as they become apparent. Reflecting on all of the above, we note that ethical challenges and issues emerge even for a carefully designed observational study run in a well-resourced facility. We cannot think of children's vulnerability in isolation of that of their family and households, and that children and families' vulnerability is layered with multiple structural drivers. Despite severe vulnerability, we've shown that mothers in particular demonstrated some forms of agency, that research inevitably interplays with these broader experiences, revealing multiple needs that is hard for researchers to respond to. but there are opportunities to engage vulnerable participants or families in research encounter and in the care of their children. I am most grateful to our research participants, our funders, the Wellcome Trust and Bill Melinda Gates Foundation, fellow researchers, colleagues, and collaborators from the various institutions. And finally, more information about the change study can be found in the highlighted link. Thank you.